Good morning. I am Dr. Veveri, Professor, Department of Pharmacology. In this video, we are going to discuss about penicillin. So these are the learning objectives. We'll be discussing about introduction, classification, mechanism of action, uses, adverse effects of penicillin, and something called as beta-lactamase inhibitors. So coming to the introduction, penicillin was one of the earliest antibiotics discovered by Alexander Fleming in 1928. And these penicillins are mainly synthesized from or obtained from Penicillium notatum and Penicillium chrysogenum. This penicillin is called as beta-lactam antibiotics. So we have a group of antibiotics, not only penicillin, we have apart from penicillin, we have cephalosporins, carbapenems, and monobactam. So all these four are called as beta-lactam antibiotics. Why these are called beta-lactam antibiotics? It have a common beta-lactam ring in its structure. That is why these are called as beta-lactam antibiotics. So coming to the example of beta-lactam antibiotics, apart from penicillin, we have cephalosporin, carbapenems, and monobactam. So as I told, this is beta-lactam antibiotics, penicillin, cephalosporin, carbapenem, and monobactam. And all this have a beta-lactam ring in its structure. So in case of penicillin, apart from beta-lactam, it also have thiazolidine ring. So all these drugs have a shares a common features like common mechanism of action, and even pharmacological action and clinical uses, all those things are shared by this group of antibiotics. So beta-lactam characteristic, they have same mechanism of action. All these four groups acts by inhibiting bacterial cell wall synthesis. And all this group of antibiotics are bactericidal. That means it will kill the microorganism. And all these are time-dependent killers, which means the efficacy will be better if the concentration above MS, the drug concentration remains in the blood above MAC for a prolonged period of time. So if these antibiotics are given for a more period of time, efficacy will be more pronounced. And they have short elimination half-life, and all these drugs are excreted mainly via kidney. So in case of renal failure, we have to do dose adjustment. And these have cross allergenicity. Suppose if they are found to allergic to have some allergic reaction to penicillin, we have to propose that it will be even those kind of patient will be allergic to cephalosporin and other groups. So this is cross allergy. If they are allergic to one group of drug, they are possible to develop hypersensitivity reaction to other group of beta-lactam antibiotics also. So coming to the mechanism of action of penicillin, as I told, it inhibits bacterial cell wall synthesis. So how it will inhibit bacterial cell wall synthesis is it binds with penicillin binding protein. So penicillin binding protein, it will bind and it will blocks the steps of transpeptidation. So once this cell wall is not formed in a proper manner due to osmotic drive, all this fluid will enter inside the bacterial cell and bacterial cell wall will burst out and die. So this is the mechanism. Even if you see in depth, this is the cell wall of bacteria. So the cell wall will be having a cytoplasmic membrane and peptidoglycan layer. Okay, so this peptidoglycan layer will be having two amino acids, actually glycan chain, which will be linked with peptide chain. So this is the structure of this peptidoglycan, and this peptidoglycan layer will provide the integrity of the cell membrane. So this glycan chain will be having two amino acid residues. One is N-acetyl muramic acid and another one is N-acetyl glucosamine. So this N-acetyl muramic acid will be linked with amino acid residues will be linked with other N-acetyl muramic acid with the help of this glycan chain, peptide chains. Okay, and this N-acetyl muramic acid will be having a amino acid residues. Here, where they will join us, yeah, this is the picture. So we'll be having N-acetyl muramic acid and N-acetyl glucosamine, and here N-acetyl muramic acid will be having a pentapeptide chains, and this pentapeptide chain one residues like L-lysine residues will be combined with D-alanine residues of N-acetyl muramic acid. And this cross bridging is called as transpeptidation. And this transpeptidation reaction is mainly mediated by a penicillin binding protein. So there will be integrity between. So all this N-acetyl muramic acid will be linked with other N-acetyl muramic acid with the help of peptide chains. Okay, so this is the thing. So N-acetyl moramic acid we have, and N-acetyl glucosamine will be having. We'll have two amino residue, and here N-acetyl moramic acid, this L-lysine residue will be linked with, or will be joined with, or we can say as cross bridged with D-alanine residues of another N-acetyl moramic acid. Okay, so this is called as cross bridge or transpeptidation, which is mainly mediated through penicillin binding protein. Coming to the action of penicillin, what it will do is this penicillin will bind with this penicillin binding protein and blocks this transpeptidation reaction in the bacterial cell. So this transpeptidation or cross bridging is inhibited. What will happen? The integrity of the cell wall is lost and the improper cell walls are formed. Okay, so this improper cell wall will due to hospital retains fluid, or fluid will go inside and the cell will swell and burst. So this is the action of penicillin. Coming to the resistance, mainly due to the production of beta-lactamase enzymes. So there are certain bacteria which produces beta-lactamase enzyme. So what this enzyme will do is just go and destroy the beta-lactam ring which is present in the penicillin and makes it ineffective. So this beta-lactamase enzymes are mainly produced by bacteria like Staphylococcus. Okay, so if this penicillins are ineffective against staphylococcal species. Okay, that is the one thing. And those bacteria which have a production of this beta-lactamase, the penicillin will be ineffective. And the second one is I told penicillin binding protein, which is important target site for binding of the penicillin. So there will be some modification in this target site so that the penicillin will not bind with the penicillin binding proteins. And the third one is impaired penetration of the drug to the target site. That means the drug will not reach the penicillin binding protein itself. Okay, and the third one is even if enter inside the cell, all this before binding with the penicillin binding protein, due to efflux pump, all this drug will be thrown out of the bacteria. So these are the four mechanisms by which the bacteria develop resistance towards antibiotics, especially penicillins. Okay, coming to the classification we have narrow spectrum and extended spectrum. Narrow spectrum means a group of antibiotics which will be active against certain type of bacteria, like only gram positive, or it may be only gram negative like that. Whereas extended, it may cover gram positive as well as gram negative like that. Okay, so narrow spectrum we have natural penicillin and anti-staphylococcal penicillin. So natural penicillin we have again acid labile and acid stable. Acid labile penicillins are destroyed by gastric acid. So we can't take these drugs orally. So all these acid labile drugs are available only in parenteral preparation, either intramuscular or intravenous. Whereas acid stable penicillin will remain stable even in the presence of hydrochloric acid, gastric acid. So acid stable penicillin, we have penicillin B. So natural penicillin, only two things we have, penicillin G and penicillin B. Penicillin B is oral form, which is acid stable, and penicillin G is acid labile. In this penicillin G, we have three preparations like benzathine penicillin, procaine penicillin, and benzyl penicillin. So these are the natural penicillin. And the second group, what we have is anti-staphylococcal penicillin. I told staphylococcal is the bacteria which produces beta-lactamase enzymes, and this beta-lactamase enzymes just go on bind with the destroy the beta-lactam ring and make the penicillin ineffective. But this group of drugs like nafacillin, methicillin, cloxacillin, dicloxacillin, flucloxacillin, what it will do is these are beta-lactamase resistant. Even if the bacteria have the capacity to produce beta-lactamase enzyme also, these drugs have capacity to act on those bacteria, especially staphylococcal. That is why these are called as anti-staphylococcal penicillin. So anti-staphylococcal penicillin we have again acid labile and acid stable. Acid labile we have nafacillin and methicillin, and acid stable we have cloxacillin, dicloxacillin, and flucloxacillin. So here beta-lactamase, against beta-lactamase, all the drugs are resistant. Then we have extended spectrum penicillin. Here we have aminopenicillin and anti-pseudomonal penicillin. Okay, here all are sensitive to beta-lactamase degradation. That means all these drugs are ineffective against the beta-lactamase producing bacteria. Okay, so here we have aminopenicillin. That is acid stable. That means we can give orally. The examples are ampicillin, becampicillin, talampicillin, amoxicillin. So among this, ampicillin and amoxicillin are the most commonly preferred. And then we have anti-pseudomonal penicillin. Here all the drugs are acid labeled. So we have only a parenteral preparations. Again, anti-pseudomonal we have two groups. One is carboxypenicillin and another one is uridopenicillin. For carboxypenicillin, we have carbenicillin and ticagrelin. For uridopenicillin, we have piperacillin, risolacin and azolacin. So this is the classification of penicillin. Okay, penicillin classification, we have narrow spectrum, extended spectrum. Narrow spectrum, we have natural penicillin and anti-staphylococcal penicillin. Whereas extended spectrum, we have aminopenicillin, carboxypenicillin, and uridopenicillin. Okay, so this is the difference between narrow spectrum and extended spectrum. So narrow spectrum effective against mainly gram-positive cells. Okay, and here natural penicillin is susceptible to beta-lactamase enzymes or penicillin enzymes. Anti-staphylococcal penicillins, those are resistant to this enzyme. Whereas in case of extended spectrum, have broader spectrum, that means apart from gram positive, it also active against gram negative. And here all the drugs are sensitive to penicillins or beta-lactamase enzymes. Okay, so we'll move on to natural penicillin. So natural penicillin, I told oral penicillin is penicillin V and parenteral preparation is penicillin G. So the spectrum is it will act against mainly gram-positive bacteria, especially all the species of streptococci like streptococci viridans, streptococci beta hemolytic streptococci, all type of streptococci. This will be effective. Apart from streptococci, also effective against Treponema pallidum, Neisseria, and Clostridium. So penicillin G, I told it is unstable in acid. So we have only parenteral preparation. If you orally, it is very, very low. And all this penicillin will be having poor penetration to the cerebrospinal fluid. Whereas if the meninges is inflamed, like in the case of meningitis, this penicillin will be having a better penetration. And all these drugs are excreted via renal tubular secretions. And after IM injection, the peak concentration of plasma will reach within 50 to 30 minutes. Okay, preparation of penicillin G, I told three. One is benzyl penicillin, and second one is procaine penicillin, and the third one is benzathine penicillin. And here benzyl penicillin can be given both intramuscular as well as intravenous, whereas procaine penicillin and benzathine penicillin are given only via intramuscular route. Okay, we'll see about procaine penicillin. Procaine penicillin is very, very long-acting penicillin. So every 12 hours, that means twice a day dose is enough. And here acid unstable, I told, and this is penicillin is sensitive. That means it is ineffective against penicillin is producing enzyme, bacteria. Okay, so the use of procaine penicillin is one is syphilis. Okay, in case of syphilis, we'll be giving 1.2 million units every day for 10 days. And the other uses to prevent subacute bacterial endocarditis. That means if the patient is having any valvular disease, even if it is congenital valvular disease or acute valvular disease, if they are planning to go for any procedure like dental extraction or tonsillectomy, they should take compulsorily with one dose of procaine penicillin to prevent subacute bacterial endocarditis. So this is the use of procaine penicillin. And benzathine penicillin, it is very, very longer acting. So every 1 month, one dose is enough. That means every 3 to 4 weeks, we have to give one injection. And here it's again acid labile and penicillin is sensitive. And this benzathine penicillin is mainly preferred for treatment of beta hemolytic streptococci. So streptococci is the one which causes pharyngitis, otitis media, everything. Okay. So what will happen is this infection is most common in children. Beta hemolytic streptococci are present with sore throat, fever, and migratory polyarthritis. Okay, so it leads to rheumatic fever. So there will be a lot of complications like it will affect heart, all the like pericarditis. It will cause. So if the patient has or if the baby is diagnosed with beta hemolytic streptococcal infection, you have to take the infection and apart from treating, have to give prophylaxis for rheumatic fever. That means one injection every 3 to 4 weeks till 5 years from the attack. Okay, when you have attack, so next 5 years you have to receive the injection. That means once monthly injection. And this is also preferred in syphilis. Whereas syphilis, again, 2.5 million units intramuscular, once a week injection for 3 weeks. Okay, whereas in case of procaine penicillin, will be giving daily one injection for 10 days. Whereas in benzathine penicillin, will be giving weekly one injection for 3 weeks. That is more sufficient. So coming to uses of penicillin, we have a lot of uses like it has been used for all gram-positive infections like pneumococcal infection which produces meningitis or pneumonia and streptococci like pharyngitis, pneumonia, arthritis, meningitis, endocarditis. Streptococcal infection, meningococcal infections, gonococcal, syphilis, and actinomycosis caused by actinomyces, bacterial infections. And apart from that, diphtheria, anthrax, clostridium, apart from clostridium tetani, gas and all those things also we can use. And spirochetal infections, rat bite fever, listeria, Lyme's disease, and it is mainly for prophylaxis of valvular heart disease. So these are the uses of penicillin. Coming to adverse reaction, so the main adverse reaction associated with penicillin is hypersensitivity reaction. So hypersensitivity reaction occurs from mild to severe form, and again, if from immediate, accelerated, and late, all type of hypersensitivity reaction will occur in case of penicillin. So apart from skin rash and mild, it also produces serum sickness and anaphylactic shock. And one more reaction is called as Jarvis Hersheimer reaction. If you are treating the syphilis patient with penicillin, due to the breakdown of this spirochetes, the patient will be having fever, chills, all those things. Okay, so this self-limited disease, nothing to worry, but this is one of the reaction which will occur when you treat the syphilis patient with penicillin. Then we'll move on to acid stable penicillin, which is penicillin B. The main disadvantage of this is very poor bioavailability, and we have to give a dosing of 4 times a day. Every 6th hourly, the patient have to take this tablet. So actually, we are not at all using nowadays, but there are some indication which even we can give penicillin B. Like if the patient can't take daily injections, like some rheumatic heart diseases. Okay, so those prophylaxis we can give this oral form of penicillin B. And then we'll move on to anti-staphylococcal penicillin. I told there are certain bacteria which produces beta-lactamase enzyme. So this enzyme will destroy the penicillin and make it ineffective and become resistant. Okay. So in order to avoid that, we have certain group of drugs like anti-staphylococcal penicillin, like methicillin, cloxacillin, all those things. So these drugs are effective even if the drug have capacity to produce beta-lactamase enzymes. Okay. So this may especially will be active against staphylococcal species. That is the one which is responsible for beta-lactamase. Apart from that, it also Actam, it also retain the action of natural penicillins like streptococci, viridans, all those things have. Also, it will be provide a beneficial effect, but apart from that, it also provide beneficial effect on staphylococcal species. So, anti-staphylococcal penicillin we have fluoxetine, fluocloxacillin, dicloxacillin, methicillin, ampicillin. Methicillin has become absolute due to nephrotoxicity, and if any of this drug are resistant to staphylococcal species, we call it as methicillin resistant staphylococcus aureus only, MRSA. Okay, we won't call that as cloxacillin. If cloxacillin is resistant, we can't tell cloxacillin resistant staphylococcal aureus. Okay, if any of this group or any drug became resistant to staphylococcal species, then we will call as methicillin resistant staphylococcal aureus. Okay, so we have oral and parenteral preparations. Okay, if you take in empty stomach, bioavailability will be a little better. And here also we have to take the drug every 6th hourly, QID, 4 times a day. And these are mainly used to treat staphylococcal infections like osteomyelitis, septicemia, endocarditis, cellulitis, and impetigo. Methicillin, due to nephrotoxicity, it has become banned, and those are resistant, any of these drugs are resistant to staphylococcal, and will call as methicillin resistant staphylococcal aureus. Then we'll move on to extended spectrum penicillin. I told we have aminopenicillin, carboxypenicillin, and iridopenicillin. So aminopenicillin most commonly drug is ampicillin and amoxicillin. So it will be active both on gram-positive as well as gram-negative like Shigella, Salmonella, E. coli, Haemophilus influenza, pertussis, all those things. And this is the difference between gram-positive and gram-negative cell wall. So gram-positive, what will happen is this is the peptidoglycan layer, and this is the cytoplasmic membrane. So this peptidoglycan layer is easily approachable to penicillins. Okay, so gram positive, what will happen is it will be having peptidoglycan layer. So all this antibiotic penicillins, if you are giving, it easily approaches this peptidoglycan layer, binds with penicillin binding protein, and inhibits transpeptidation reaction. Whereas in case of gram negative, what will happen is this peptidoglycan layer is sandwiched between two layers. One is cytoplasmic membrane and another one is outer membrane. So this outer membrane is rich in lipopolysaccharide and which have a porin channels. So those drugs which have highly hydrophilic characteristic will only enter inside this porin channel and reach the target site of that is penicillin binding target site, that is the penicillin binding protein of peptidoglycan layer. So this is the difference between gram positive and gram negative. That is why some of the drugs are ineffective against gram negative. But ampicillin, amoxicillin, and this group of drug which have capacity to reach enter inside the sporin channel and act on the peptidoglycan layer. And this is the spectrum. So apart from gram positive, it also active against gram negative like E. coli, Shigella, Haemophilus influenza, all those things. Okay, and there are some difference between these two drugs, which most commonly used ampicillin and amoxicillin. So again, ampicillin, the concentration of reaching cerebrospinal fluid will be more in case of ampicillin during inflammation, whereas amoxicillin is little low. Okay, and again, food decreases the bioavailability of ampicillin, whereas amoxicillin, there is no any food interactions. And diarrhea is also more common with ampicillin. So all these things are most commonly seen with ampicillin, whereas in case of amoxicillin, you usually don't see. So we have extended spectrum aminopenicillins. Okay, that is ampicillin and amoxicillin, those group of it. So these are active against gram-negative organisms also, and all these things are acid resistant. So can be taken orally, but penicillin sensitive. So again, those bacteria which produces penicillin enzymes, it will become ineffective. Okay, and again Pseudomonas, it will not be effective. Okay, whereas in order to overcome these adverse effects, we have anti-pseudomonal penicillin. That is other two like carboxyl penicillin and uridopenicillin are effective against pseudomonas infection also. That is why these are called as anti-pseudomonal penicillin. Those group of drugs, carboxyl, ticagrelin, and piperacillin. Okay, so carboxypenicillin, we have carbamazepine and ticagrelin. Carbamazepine again became absolute. We have only ticagrelin in this group, and it have an extended spectrum apart from gram positive, gram negative, also active against Pseudomonas aeruginosa, and these are not acid resistant. So we have only parenteral preparation, and again, so penicillin is resistant. Okay, so usually in order to improve the effect, will be use this penicillin along with aminoglycosides to have better extended broad spectrum coverage. Okay. Then uridopenicillin, we have piperacillin and azoxystrobin. So this also active against gram positive, gram negative, and pseudomonas. So piperacillin usually effective against Pseudomonas, indole positive protease, Klebsiella, and Enterobacter. And this is one of the most active penicillin against Pseudomonas. So if you have a Pseudomonas infection, this is the first line of drug we are choosing nowadays. Okay, and usually combined with aminoglycosides. So these are mainly used to prevent Pseudomonas infections like in septicemia patients, burns patients, UTA, and immunocompromised patients. Adverse effects mainly with platelet dysfunctions and sometimes post thrombocytopenia, neutropenia, all those things. Sorry. So penicillin adverse effect, I told hypersensitivity reaction. So it produces immediate, accelerated, late, all type of hypersensitivity reaction. So immediate occurs within 30 minutes of parenteral preparations. Okay, so even from skin rashes, fever, eosinophilic angioedema symptoms, and patient may lead to anaphylactic shock. If the patient has developed anaphylactic shock, you have to treat the patient immediately with adrenaline injection, hydrocortisone injection, and antihistamines. So it is always to have a skin test or allergic test before giving penicillin. If you want to proceed with penicillin, make a skin test. Okay, if the patient is not allergic, you proceed. If patient is allergic, you can go for some other group of drugs. And accelerated usually develops within 72 hours of drug administration, and late usually occurs after 72 hours of penicillin administration. Then GI upset. This is more common with ampicillin. It produces glossitis, stomatitis, and even taste alteration and diarrhea, all those things. And third one is superinfection. Superinfection is mainly due to damage of this intestinal flora due to some antibiotics. So antibiotic induced diarrhea is called as superinfection. So if you give penicillin, have a chance of producing superinfection is high with this case of group of drugs. And if the patient has developed superinfection, you have to treat with oral vancomycin and metronidazole. Yeah. Then something called as beta lactamase inhibitor. So what is beta lactamase inhibitor? I told certain bacteria will produce beta lactamase enzymes, and these enzymes makes the penicillin ineffective. So in order to overcome that, we'll be combining penicillin with beta lactamase inhibitor. So what this beta lactamase inhibitor will do is just destroy the beta lactamase enzyme produced by certain bacteria and make penicillin to act. So have synergistic effect. or it will improve the effect of penicillin, efficacy of penicillins. Okay, so here we have clavulanic acid, sulbactam, tazobactam, vaporbactam, relibactam, and ziribactam. So these are the group of beta lactamase inhibitor we have. Usually it doesn't have antibacterial action. The main thing is to improve, in order to improve the efficacy of penicillin, we usually combine this beta lactamase inhibitor with penicillin. Once after destroying the beta lactamase enzymes, so it will become, this drug will become ineffective. So that is why this group of drugs are called as suicidal inhibitors. So it inactivates bacterial beta lactamase and are used to enhances the antibacterial action of penicillin. Okay, and have only weak antibacterial action, available always with fixed dose combination of penicillin. Okay, so you have clavulanic acid, it always available with amoxicillin. Amoxicillin, clavulanic acid, that is augmented 625, that is amoxicillin 500 milligram and clavulanic acid 125 milligram. So it will act on methicillin sensitive staphylococcal aureus and respiratory infection caused by streptococcus pneumonia, Haemophilus influenza, and Moraxella orthosis. Adverse effects is very, very rare. Sometimes it causes rashes and GA adverse effects. And these are the beta lactamase inhibitors combination available with penicillin, like ampicillin, sulbactam, amoxicillin, clavulanic acid, ticagrelor, clavulanic acid, and piperacillin, tazobactam. So sulbactam is usually available with ampicillin. So it also covers anaerobes. Apart from gram negative and gram positive, it also covers some of the anaerobes. Okay, and this sulbactam combination is very, very active against Acinetobacter species. Then tazobactam, this is always available with piperacillin, it's broad spectrum penicillin. So for pseudomonas, most commonly preferred dose is 4.5 gram IV 6th hourly. Coming to drug interaction of penicillin, we have some of the drugs which will produce antagonistic effect and some will produce synergistic action. So antagonistic action, one is bacteriostatic drug. I told this beta-lactam antibiotics are bactericidal. So always bactericidal drug should be combined with bactericidal and bacteriostatic will be combined with bacteriostatic. So we should not combine bactericidal drugs with the bacteriostatic drug. If you combine, the efficacy will be reduced. And the second one is always aminoglycoside provides a beneficial or improve the efficacy. Its coverage will be in broad spectrum, but if you combine penicillin and aminoglycoside in the same syringe, both will inactivate each other. So always give penicillin separately and aminoglycoside separately. And third one is allopurinol, which is the drug used for gout. If you combine penicillin with allopurinol, the chances of developing hypersensitivity reaction is very high. And again, the last one is hydrocortisone. The same thing like aminoglycoside. We can't combine hydrocortisone with penicillin in the same syringe or IV fluids. If the patient is suppose we are infusing normal saline, so we can't combine hydrocortisone, penicillin, everything in that. So we have to give a separate injection of hydrocortisone and penicillin. And there are something which have synergistic combination. The first one is probenecid. It's also the drug which has been used for gout. So what this probenecid will do is it will inhibit the tubular secretion of penicillin. So if this tubular secretion of penicillin is inhibited, penicillin will be available for a more period of time. So the drug will be acted in a prolonged period. Okay, so in order to improve the efficacy of penicillin, we always combine with probenecid. And then beta lactamase inhibitor that has been told and we had seen about beta lactamase inhibitor. So this beta lactamase inhibitor are always combined with penicillin in order to improve the efficacy of penicillin. And the last one is aminoglycosides. So aminoglycosides have synergistic effect, but don't combine both the drug in the same sense. So how to give separately, like penicillin separately and aminoglycosides separately. This is the case scenario. A middle-aged man presented to the OPD with painless penile ulcer for 5 weeks. On examination, he had ulcer in the mouth and plaques on the neck too. Serology and VDRL are positive. So what is the drug of choice? Classify the above group and write the mechanism. List the uses of above drugs and what is suicidal inhibitors. Okay. So this is a case of syphilis. Okay, the patient have painless penile ulcer and post serology VDRL are positive, and even examination the patient had some other acid in the mouth, all those things. Okay. So what is the drug of choice here? So drug of choice is either, actually here it is benzathine penicillin, but even if you write procaine penicillin is also correct. Either you can select procaine penicillin or benzathine penicillin. But the advantage of benzathine penicillin is one injection once a week for 3 weeks. Only 3 injections is sufficient to overcome this to treat syphilis. Whereas in case of procaine penicillin, you have to give daily injection of 10 days. So patient have to take 10 injection. Whereas benzathine penicillin only 3 injection, that is once in a week. Okay, so gap also will be there. So here the drug of choice is mainly benzathine penicillin, 2.4 million units intramuscular once a week, 3 weeks. Okay, and classify the above group means you have to classify about penicillin and write the mechanism, how it acts, how it inhibits the transplantation steps, all those things you have to write. And the third one is list the uses of above group. So you have to write all the things. Okay, so narrow spectrum active against which gram positive. So what are the uses like streptococcus and add streptococcal penicillin against streptococcal infection, pneumococcal meningitis, trypanosoma pallidum, syphilis, diphtheria, anthrax. Okay, so gas gangrene, clostridial infection, all those uses you have to list here, and even pseudomonas infection, all those things. Then what is suicidal inhibitor? Is I told it is beta lactamase inhibitor, like lavalic acid, sulbactam, tazobactam. Those group of drugs are called a suicidal inhibitor. Why is these drugs are mainly to improve the efficacy of penicillin. Doesn't have any antibacterial action. So once it destroys the beta lactamase enzyme produced by certain bacteria, it became ineffective or it will become destroyed. Okay, it will die. So that is why it is called a suicidal inhibitors. Okay, so this is about penicillin. Thank you.